Good afternoon, everybody, and thank you so much for joining us today. Whether you're joining from near or far, we are thrilled to have you here for this exciting presentation. My name is Deb, and I'll be your host for today's session. And we have a truly engaging and insightful presentation lined up for you. And we are confident you'll find the information shared today very valuable. As a reminder, the webinar is being recorded, and you can revisit the content at any time on our YouTube channel. Before we dive in, I'd like to cover a few housekeeping items to ensure you have the best experience possible today. First, if you have any questions throughout the presentation, please feel free to use the chat feature, and our team will be monitoring it, and we will do our best to address your inquiries. We'll also have dedicated Q&A at the end of the session. We encourage you to actively participate, and if something resonates with you, don't hesitate to share your thoughts in the chat.
Thank you. Let me share my screen.
Hello, everyone. My name is Marie Jackson, and I have the opportunity to introduce the speaker today. We are so excited and honored to have Dr. Daniel J. Smith. He is Associate Professor in the College of Graduate Health Studies in the Public Health Department at ATSU. Since 2002, Daniel has experience teaching online and in-person biostats, doctoral research methods, healthcare administration, and data analytics courses for both public and private institutions. Dr. Smith's passion is serving students in building their knowledge of biostats and healthcare administration. Daniel has an MBA and a PhD from Arizona State University. He currently resides in San Diego, California with his wife, who is a bariatric physician, and his son. They enjoy winter backpacking and spending time at Legoland, Disneyland, and my favorite, the beach. In 2024, Dr. Smith was awarded funding from the ATSU Community Health Workgroup Quality Improvement and Research Pilot Grant Project Grant. He was the primary investigator for an innovative community health project, aligning with ATSU's strategic focus on improving community health research outcomes. Today, we are so excited to hear about this research outcome from this grant. So I will turn it over to Dr. Smith without delay. Dr. Smith.
Thank you, Marie. And I'll say Marie was very instrumental in helping us to obtain this grant. So thank you, Marie. And she continues to be a very valuable resource for us as we apply for other grants. I'll bring up the PowerPoint. Can everyone see that? So I hope that we get a lot of dialogue, and I hope you have a lot of questions for me at the end, because that's really what makes this so special. You could actually go to the ATSU library and look up this article there. It was published in the American Journal of Hypertension this year. But I hope we get a lot of great dialogue about any questions you have, or the continuation of this research. And so this research was completed maybe 3 months ago, and it's about the impact of cost sharing on self-measured blood pressure cuffs, actually. And so if we think about the triple aim of healthcare, we have cost, outcomes, and patient satisfaction. And sometimes we add into that provider satisfaction as well. This study touched on cost and to some extent outcomes of patients. And access is really a buzzword around healthcare organizations. They're always, one of their missions is improving access to care. And it's quite complex because you have healthcare organizations who take care of patients, and sometimes they're also affiliated with insurance organizations that want to have some sort of cost containment, but also proactive methods to reduce costs. And so if you think of those two things as we go through the presentation, I think you'll have a good context for what we did. And so this was conducted with Dr. Lisa Soltani and also an analyst at El Rio Health, Grace Parker, in Tucson, Arizona. So yeah, the team. So it was me as the lead researcher, and from Al Rio Health in Tucson, Dr. Sultani Erin Daughtery, who is the administrative researcher on the Al Rio side. She helped a lot with the grant component of the research, and Grace Parker, who is an analyst. And this was in the Department of Internal Medicine. We received an ATSU internal grant for this study that helped us to fund mostly the analysts to retrieve the data that we needed for the study. And then also these blood pressure cuffs for patients were sponsored by the National Hypertension Control Initiative, which was sponsored by HRSA and also the Office of Minority Health. And it involved 4 student researchers from various departments at ATSU. Nitish, Vincent, Emily, and Subhash. And 2 of these students continue to be an engaged member of our CGHS research team. And so they meet with us monthly, and their research with us is ongoing. And so they actually, I just want to show you this. This research won a relevance award this year for the impact of cost sharing on self-measured blood pressure cuffs, patient cost, and prescription abandonment. Um, and the relevant, so this is Dr. Sultani over on the right. She actually presented the poster, but the students created the poster, but they were virtual. So they attended online, but Lisa was on site. And I want to mention that this was not a student conference. This was a conference open to practicing physicians and researchers. So it's great that they actually won this award. So what's this study significance? So I want you to think of this blood pressure cuff. Now you could buy this, you could purchase this at Target or Walmart. The retail cost of this is $70. This um, durable piece of medical equipment that you see on the screen, DME. Um, but it in health systems, it's $35. So we're talking about a $35 piece of equipment, this one. It's quite simple, but it has big impacts on patients. So the background of the study is that not all patients receive insurance coverage for that cuff that you just saw. Um, and so also it's difficult for patients to navigate which cuff to purchase. And it's sometimes difficult for the providers, for example, the physicians, to know which cuff to recommend. And El Rio Health serves 21,000 patients with hypertension disorder. That's 29% of their adult population. And so this study evaluated the impact of this $35 device on prescriber behavior and patient behavior. And we wanted to understand the role in this blood pressure cuff in diagnosing and controlling hypertension. So the idea was that patients with hypertension would use this cuff in the home environment to measure their blood pressure on a daily basis. And then it would record the readings that they could bring into the physician to read so that the physician could have some long-term sort of outcomes and readings from the patients. So we wanted to evaluate in a sort of an economic study. We wanted to evaluate the impact of cost sharing, which I'll explain more, on prescribing patterns of physicians and patient uptake of those prescriptions written. And so at the end of the study, we wanted to determine how a financial barrier to obtain this blood pressure cuff may affect both their behavior and the provider behavior. So we could create evidence-based policy recommendations for improving patient access and improve care. So as I mentioned, there are 21,000 patients at Real Health with hypertension. 29% of the adult population that they serve has hypertension. and 10,000 monitors were dispensed during this grant period. So around $350,000 of blood pressure cuffs. It was a 3-year grant period. And so the idea is that patients could receive a free blood pressure cuff. And if you look at a picture of Al Real Health, the pharmacy is on site. So they would not have to leave the clinic, the ambulatory clinic, and go to a pharmacy to pick it up. So essentially, there was some prescriber influence on the physician to make a prescription for this blood pressure cuff because it was free and it may benefit the patient. The patient had the incentive of picking it up because it was free and they could pick it up on site. So those three factors contributed to the analysis. So what we did is we compared the final 6 months of the grant, which was the free blood pressure cuff, and we chose the final 6 months of the 2-year grant, actually 3-year grant. We chose the final 6 months because those months were when the providers themselves were most familiar with the procedure of writing these prescriptions, so it affected them. And also, then we could compare that to the first 6 months after the grant, when the blood pressure cuff became $35 for the patient. And we use Epic Electronic Health Record System for the data. And we included all patients that received a cuff. So it was tens of thousands of patients. And we ran a Wilcoxon rank sum test at a 95% level of confidence, which is very high. It's, I'll just say in my like 15 years of working in analytics and healthcare, it's very rare to achieve significance with this very high threshold, but we did. So in 2023, during the period of free monitors, 2,619 prescriptions were written by providers and 90% of patients picked them up. So we only had 10% abandonment. Um, However, in 2024, when the patients had to pay for the monitors, only 1,600 prescriptions were written with the same patient volume. So prescribers were writing fewer prescriptions, and almost half of the patients, even when they had a prescription, did not pick them up. So, so if you include the number of fewer prescriptions written and the fact that fewer patients picked them up, 59% fewer patients received monitors. And this is over $35 for the monitor. And so if we think about that price, during my time in healthcare, we always called it population health analytics. If a patient were to visit the ED, that one visit, especially if they were admitted, that one visit could be, tens of thousands of dollars. Maybe if they just visited the ED, the emergency department, it might be $2,800, which is much greater than the cost of these blood pressure cuffs. And so it's somewhat short-term thinking to reduce the subsidy of these blood pressure cuffs when later you'll have outcomes which are much more costly. And so when we reduced it, we had a statistically significant outcome of reduction, which means the reduction did not overlap with zero, um, between 28 to 32% reduction, and for both fill rates and a little bit higher for prescribing. So something was happening here in the process with both the pickup of these cuffs when the patients had to pay $35 and the behavior of the physicians. And here, uh, sort of the impact visualization with bar graphs, uh, we can see that far fewer prescriptions and the fill rate was much lower. And so what are the insights? So even with a somewhat relatively small cost that will affect access to care for patients. And if physicians know that their patients have to pay $35, they write fewer prescriptions. In fact, I'll just say without sharing anything private that one of the complaints that my wife's patients always have is that she's making money on their prescriptions, that she's somehow involved with a pharmaceutical company when she writes prescriptions. Maybe once a week, a patient becomes upset over costs. And so that type of thing can affect physicians. Um, and a centralized dispensing at ambulatory clinics is very helpful for fill rates. So in the health system where I worked, we had 50 hospitals and roughly 500 ambulatory locations. That's a lot of pharmacies. So that may not always be possible to have that set up, but it's very helpful. And so there's broad agreement that these blood pressure cuffs help to manage hypertension. But when payer coverage does not provide one, um, far fewer patients will have access to them. So for healthcare organizations, the recommendations are to eliminate or minimize any sort of costs for these durable medical devices, implement centralized dispensing, and partner with insurers to improve and standardize coverage. So I know in my, actually at Banner Health in Arizona, um, there were times, in fact, pilots, when patients would receive new carpeting in their home. If, for example, there was something affecting them from something in the home that would make them go to the ED, especially when they were connected with insurance and ED visits. So for policy makers and payers, consistent insurance coverage is helpful. Supporting FQHC programs is helpful. Of course, this is the perspective of from the FQHC. And then for future research, actually evaluating the patient impact of the clinical outcomes from monitoring blood pressure is helpful. And uh, we need more multi-site studies across more diverse populations and settings. And so that is next, actually. And Maria's we're working on something else for sort of a part two of this study. I think, I'll just mention a few limitations as I mentioned. That it was only completed at one FQHC center, this study, and the observational design limits causal inference. And we were unable to determine if patients obtained monitors, the blood pressure cuffs, through other means. Uh, and we did not formally assess the impact on blood pressure control outcomes, and there were only 6-month comparison periods. But we did have a total of 4,200 prescriptions written. So it's a quite simple conclusion, and that is subsidizing even relatively low-cost durable medical equipment items dramatically improves access to care, both because of the prescriber patterns and also because of patient uptake rates. And that was our study. Thank you. I would love to have questions. Or-
The Dr. Hasty had a comment that it was such an incredible fill rate.
Yes, yes. So I'll say people love getting free things, I think. And so I know from anecdotal conversations with the providers that they did not always even use them, but they wanted to pick them up. Yeah. Okay, Dr. Matthew, I think I see a question from Dr. Mathewson. Yes, please.
Hi, yeah, thanks, Daniel. That was so great. I had to come in a couple minutes late, but saw most of the results. I wondered if for the blood pressure outcomes, are there plans to look at that? And then are there also plans to
Yeah.
look at sort of the cost, I guess, potential cost savings associated with the home blood pressure cuffs?
Yes, to both questions. And actually, we would like another grant to do that. And so there's two pieces. There's the clinical outcomes piece and sort of the longitudinal data related to the uh, this blood pressure cuff and the clinical outcomes over time, but also interestingly, the social determinants of health. And so there, we're working with again our Real Health, Banner Health, and another healthcare organization in Arizona that has the social determinants of health information for us. It's mostly based on zip codes of the patients, but we want to determine if there are, I'll say, some qualitative factors that also affect both the usage rate, the uptake rate, and then the clinical outcomes. So yes, and I'll say uh, that as a chronic condition, that's one of the uh, priorities of the current Trump administration. And so there's some chance that we could obtain an NIH grant around this, I say, with conservatively. And so we're going to try.
Dr. Freeman's hand was up. So, Dr. Freeman, if you want to.
Yes, thank you, Dr. Roy. Dr. Smith, very interesting proposal. My experience in community health centers tells me that the patient population at El Rio might have been inquisitive about why they would be asked to participate in a study. Oftentimes, the population served by a community health center feels preyed upon by
Hmm.
researchers, and oftentimes their complaint is that the study outcomes are not shared with them subsequent to the study. So I think that's maybe my question. Do you have plans for sharing with that group of 4,200 how what the outcomes meant, the suggestions that we've learned?
Yeah, that's a great question. And I'll say, of course, all data was de-identified. Even if I wanted to, I don't know who these patients are. I didn't even have an Epic record ID. So obviously somewhere someone has that. And we know that they were part of this healthcare center. Um, and there is some continuity of patient care as well in this population. So it's very likely that they will return. They knew they were part of the grant, as you mentioned. Um, and so, yeah, that I think there was of course, the poster presentation and entire conference on site at El Rio. They invited U of A and a lot of different institutions to that conference, but I don't believe a lot of patients attended it. So that's a roundabout way of saying we don't have plans to do that yet, but I think that could be interesting. And also that could also serve another research purpose, which is to get their insights on why was the fill rate, so why did you pick it up, right? Why was, when it was free, did you acquire the device? And what would prevent you from doing it when it was $35? Did you actually use it? Do you think it was helpful? So there's the perception of helpfulness, and then there's the, or efficacy, and the actual clinical outcome as well, which might be
Mhm.
interesting to compare. Uh,
People who live in abject poverty aren't accustomed to being asked for their opinion.
yeah, yeah,
And maybe just a one pager that is written um, in an appropriate manner
yeah.
that could be distributed to that group by postal mail, even. Um, that might be a prospect. And just let me suggest that $35 for someone who is wondering where their next meal is coming from is a lot of money. So I'm not surprised at all, and nor am I surprised by the provider behaviors, because the providers are preemptive in recognizing that their patients aren't going to spend $35. They can barely have $2 available, many of them, to make the trip in to see the provider. And it begs a second question, just very briefly. What do you think would happen if you replicated the study at Banner, where it's likely that the median income of the patients is higher?
Yeah.
And in different populations, might we have similar outcomes, Dr. Smith?
Well, so some of the main, great question. Thank you. So some of the main drivers of quality care was actually two things. Actually, well, three. One is knowing English well. Then the other one was level of education. And then interestingly, and this is intuitive, it's how many people around you in your community, like your family, care about you. So if you're completely alone in a city, your quality, your clinical outcomes are much more likely to be worse. All other things being equal. Um, and so I think it if we hold those things constant that I just mentioned, because I think they affect everyone, uh, I think that the same prescriber patterns would be evident, and I think the same fill rate patterns would be evident. But one thing I think would change is a greater use rate. So just because you have this monitor doesn't mean a couple of things: that you'll use it and then you'll use it at the correct interval, and then you'll even remember to bring it back to the clinic so the provider can read the results. Most of the time they would forget it at home, anecdotally. Um, and so it's actually, this is so interesting. It's actually a lot of patient participation and engagement for success here. And I think that really relies on a lot of factors. Um, more frequent check-ins, for example, maybe even virtual care to see the patient, because maybe transportation is challenging. Um, so that sort of lives in the entire ecosystem of the patient, right? Which is likely a quite fragile one. Any one thing can affect what happens. But I think overall, people and providers, patients and providers are more likely to obtain something if it's free than if they have to purchase it.
Thank you
There's
for
a
your scholarship very much.
there's a question in the chat from Cindy. How did the BP data get collected on paper or electronic?
Yeah. So the honest truth is, I'm not exactly sure of the exact mechanism, but somehow this blood pressure monitor has some sort of memory device within it. And then the physician would read that memory. Maybe it was even on the screen of the blood pressure cuff, like they would scroll backwards, and then they would enter it into Epic, the date and the blood pressure reading. And so that brings up another point, which is that not all providers use Epic equally for a lot of reasons. In fact, I know of providers that break the rules quite often, and they don't even enter notes into Epic until like a week later, after they've seen a whole week of patients, for various reasons. One is because they get busy and they want greater patient throughput. And so sometimes the notes are quite weak, which is a whole another clinical informatics component of this. Is the provider also has to do the right thing and enter the information into Epic.
Dr. Smith, I have a question.
Yeah.
So I'm assuming a lot of these patients are on Medicaid,
Yes.
And with the new legislations about work requirements and with the projections of the number of people getting kicked out of Medicaid because of the work requirements, how would a healthcare system take care of of its patients that get disenfranchised?
Well, I don't know all the policy implications of that, obviously, but I will say that that's always been the case. And I'll say accountants call that charity care. So there's no reimbursement for the encounter. Um, and so the physician receives RVU credits for whatever took place during the encounter, but the system itself sometimes does not receive funding. And so I'll tell you, at Banner Health, no secret, you can Google it. There was a large layoff recently because of that. All directors and above received an email that you can resign and receive a payout or risk being fired in a month and no payout. And it was kind of like random. You didn't know because they're receiving less reimbursement. So they had to save like 22 million, I think. So some executives I see on LinkedIn even uh, were terminated. And that's the largest private employer other than the government and Walmart for employee count in Arizona. Yes, Marie.
Thank you, Dr. Smith. That was a great presentation. I learned something every time. Uh, so I'm curious, you had a number of students working with you. Can you describe how that worked and how, I know you have a heart for the students as
Yeah.
well as the community health center. So how did that kind of all come together and what was that like?
Oh, this is a great question. I love answering this question because I've given it a lot of thought. And um, the answer is I even feel awkward presenting today because I always like to put the student in front of the research, like be there for them, but let them learn and present, right? So working with students was interesting because it was quite a large team. So we had our real health, we had me, and then we had the students. And sometimes, especially for publications, we needed something like quickly, like what was the actual outcome of the Wilcoxon sum rank? And did you include these patients? And what did you do? And sometimes the students, I mean, I could look at their work in Excel or SPSS, whatever they use, because we had a Dropbox. But I think one of the challenges I learned about it is that when I had the students do the stats, uh, good documentation, just like in the workplace, is super important. What was actually done here? Because sometimes students would take a day or two to follow up when I needed it in like an hour. Um, and that's my fault for leading it that way. But it was wonderful having students being involved in it because um, the hardest part with any study, especially in healthcare, is getting the data. And we had fantastic data. So it was all fun with statistics. And they enjoyed that as well. And a few of them I mean, I almost felt like they work for me in a way because they keep asking for more, and I don't always have more immediately for them. So I think the students enjoyed it a lot. They learned a lot in the process with the statistics, for example, that they might not always do on their own. And also what was great about it is that I could leverage each student's strength. So some of them were great at the write-up, some of them were good at the literature review, some of them were great at the technical components of the stats. And the four students I worked with all had different strengths. And that made a great team just by luck, I think, a little bit. Um, and so, yeah, that's why we're here. That's why I'm here, is for them, not for me. And in this case, really not even for patients, because I don't work for a healthcare organization. I work for students. And so, um, despite the fact, arguably, was it a little slower work? Yes, but that's part of learning. And so I think that's a great experience.
And I think it's amazing that, right out of the gate, the first experience and they won an award. I'm sure that was pretty impactful for everyone, but particularly for them.
Yeah.
Hopefully they will continue their research careers. So that's very exciting. So
I-
to me, that speaks to your mentorship. So well done.
well, yes. And to that very point, um, it's so easy to forget, like I'll call myself mid-career if I can. It's so easy to forget how much just one study can contribute to an early career CV. Because that may be the difference in an interview between someone that's done nothing, just coursework, and someone who actually can bring some experience to the employer. It can make all the difference for a job applicant. Yes, Leanna, I think you had a question.
I do have a question, and I just finished your biostatistics class.
Oh,
Please don't ask me any biostatistics questions, though.
yes, I remember we spoke. Yes, great.
All my questions, yes. Um, so my question is, and I'm sorry I missed the first few minutes of your presentation because I was on another meeting,
Yeah.
but when we talk to our students about pursuing a quality improvement project or a research project, we really try to highlight the importance of a needs assessment or find out what the community needs,
Yeah.
not only what you think the community needs. So if you already talked about this, my apologies, but I
Oh, no.
am curious about how you initially decided to do this project at this location.
Yeah. So I'll try to answer as briefly as I can, but this is like the centerpiece of all analytics, right? So in reality, when you work for an analytics company, a senior vice president has had a meeting earlier in the day and suddenly you have to fight a new fire and explain the other priorities from last week and try to fit them in, right? That's the reality of working for one of these healthcare centers. But as a researcher myself, I have to go to the data with our community healthcare partners. So uh, if like in this case, they had a grant so they could receive this blood pressure cuff monitoring device. Um, and they were curious to know what the results were. Um, that and also they knew they had really good data around it. So, I mean, we paid the analysts in this case. I don't know how much, like, let me think about it for a second. Almost 3 weeks of her full salary to even get this data. So, like working in a healthcare company, uh, it can take an entire quarter to get all the data assembled. And we just don't have the funding or the time or the priority to actually do that. So I guess I'm answering in a practical way as a researcher. I have to go where the curiosity is, which and obviously we can build a literature review after that. And also where the data is retrievable in a halfway uh, reasonable way. So did that help? I hope that helped answer it.
Thank
There
you.
might, yeah, there might be some disappointment there in the fact that both as a healthcare worker in analytics and also as a researcher, there are so many things you could study, and um, but I think it's a real luxury to study what you want with the real world sometimes because it requires funding. And so the way the healthcare companies pay for that is they have an ROI attached to it. So can we get fewer ED visits through these blood pressure cuffs and paying me to figure that out? Um, but you can't really, I mean, it's very hard to come up with something unless resources are, and I know that, yes, Alan.
Well, additionally, the Health Resources and Services Administration and other government entities often establish your priorities for you if you are
Hmm.
partially or fully funded by those organizations. So that's a great place to look for what the government, at least, and sometimes that's politically motivated, And sometimes it's based on good evidence, good science.
Yeah.
But that's a good place to begin to find areas where there are gaps. Would you agree, Dr. Smith?
Yeah, fantastic. And I'll only add to that sometimes wealthy donors. Uh, ASU had, no, Banner Health has an Alzheimer's Institute with very high caliber researchers, like seven-figure earning researchers, paid for by wealthy donors. So that's a little bit outside of insurance and federal government, but they have this kind of trust fund to study that. But yeah, no, otherwise you have to go where the money is. That's right. Which is sort of sad, right? But it's the reality. Yes, Marie.
Yeah, and to kind of add to that, so El Rio is pretty savvy when it comes to research. And
Yeah.
so they really, Dr. Saltani really had questions that she wanted answers to, because they gave out 10,000 blood pressure cuffs, and what was happening with those. And so as Dr. Freeman stated, one of the UDS measures is, decrease in blood pressure. And so their blood pressure, I don't remember what the initial number was, but they really saw a decrease in their blood pressure, well, an increase in their blood pressure control. And so Dr. Saltani was like, what is happening? Why is this happening? And so was it, part of the blood pressure cuff dispensing? And so that's kind of how the conversations began. It really came from El Rio to ATSU.
That's
And then
right.
Dr. Smith got involved.
Yeah, there was a real curiosity there, as you mentioned, and Dr. Soltani is a great researcher. I'll mention though, a lot of physicians believe that they're always great researchers, though, when you work with them. And so that's part of navigating working with these community health centers as well, is that there's an art and science of medicine, but sometimes an underestimation of the art and science of doing research. Not on from El Rio, but just in general. But they were a fantastic group to work with, as you mentioned, and they had a passion that was incredible. Um, and I'll say that passion I observed was not just for making money, as many large healthcare systems are, to generate more revenue or cost savings, but rather really to help the community, um, which is, I'll say, unique, with what I've done, at least.
I might add there again, and I know we're probably going over, Dr. Roy, but 1 in 6 Medicaid patients in the United States is served for their primary care needs in a community health center. There are 1,500 of these
Okay.
organizations across the country. So it's a seat at the table when it comes to policy development in the United States these days, and has been since 1965. So um, again, a very interesting study. My guess is 75% of the studies that would be accomplished in those 1,500 would would provide exactly the same result, or a
Yeah.
similar,
Yeah.
substantially similar result as you're
Yeah.
providing us today, because
Mm.
it's an underserved, vulnerable, disenfranchised uh, collective there.
Yeah. Well, multi-site study would be great. In fact, we published in a tier 2 journal, not a tier 1, because tier 1s require multi-site validation of the replication of those outcomes. But I think we could get that actually if we did extend that. Yeah. And also what you mentioned reminds me of the fact that a lot of these patients have diabetes and obesity, which leads to other chronic conditions. So this is all linked together. It's not just hypertension. A lot of them are polypharmacy with 8 or more medications, diabetes. It's a very complex thing. And what can you start with? Is it this $35 piece of equipment that might help them control other chronic conditions they have? So yeah.
If there is evidence for its efficacy, which there is, should we start doing trade-off studies to show if allocation of resources into these DMEs
Yeah.
and other factors that control chronic conditions actually save us money. As I kind of never found trade-off studies done in chronic conditions.
Yeah.
Those might be interesting if they have good cost data. That
Yeah.
is, what is your experience with cost data at CHCs, Dr. Smith?
Well, I don't have a lot of experience with this type of healthcare organization, more like large ones like Banner Health. But I'll say, unfortunately, well, this is provocative to say, but a lot of times research, operational research um, is not inspired by the literature. It's inspired by their observation every day in the hallway. And so that may or may not be actually what's driving cost. And so there'll be a physician executive with 22 years of experience who says, okay, team, I want to take a look at this. And you'll spend 3 months taking a look at that when perhaps there are, I don't know, there might be academic articles already written about that or studies. In all of my time in healthcare analytics and leading teams, I think not once did we use an academic article, sadly. We used executive intuition. And good luck trying to get around that oftentimes. In fact, in a way, being a better communicator with executives and really knowing what they want is what differentiated the analysts from the directors and VPs. And so, I mean, that's another recommendation is how do you really disseminate this knowledge so that others are inspired to learn something from it without having to do the whole study? Um, and then there's the other component of the overhead of doing this type of analysis. Um, uh, Arguably, sometimes doesn't have an apparent ROI. Um, and so there's always the idea of just we own these patients' outcomes and all the care they receive. Let's try to just turn everything down so that we can reduce the costs. And sometimes you have to spend more to save, right? Um, yeah, so there's a lot of things going on there and a lot of social things. This is more like a sociology, a psychology study in a way than it is an academic one with math. Um, and sometimes even when you present the math, I'll tell you another barrier to implementation. They'll say, oh, wait, did you do this? And so you get 42 minutes of questions and answers to try to say, ah, that's not what I've always observed, which is sometimes the case. But in other times, if it doesn't align with kind of the thought process of what what leaders want to achieve, it's not implemented, if that makes sense. So that's why your statistics have to be very clean and very well documented from Epic. And uh, I mean, what differentiates, again, an analyst from a vice president is their ability to tell a compelling story with the exact same data. Yeah.
Well,
Wow.
there's a compelling story, friends, on the global stage, and that is that there are 19 industrialized countries.
Yeah.
18 of them have universal access to care. We could look at Norway and Finland and a couple of other examples in the Scandinavian part of the world and see social policy, public policy that is effective because they've grappled with the idea that every human being has equal value.
Yeah.
I'm sorry to say that in my 66 years, I've yet to see it in the country that I love. So that might be at a higher order where we begin with our analysis today.
Yeah. Yeah. Well, in their defense, it's so overwhelming. All of the decisions you can make, and you know, there's a lot of factors to consider um, that no one person can overcome. Arguably, cultural factors. I knew the questions and answers would be the best part, not the fact that people love free blood pressure cuffs. So, yeah. All right. Well, I hope to come back in the future and present a follow-up on kind of a part 2 of this, which is the clinical outcomes piece and more about the social determinants of health, and maybe even a thematic analysis around patient satisfaction, perception, and that type of thing. We'll see where it leads us next. I think we have everything lined up. We just need to execute on it.
Absolutely. Thank you, Dr. Smith, so much for speaking to us today. We learned so much. And that brings us to the end of today's webinar. On behalf of ATSRI, I would like to extend a huge thank you to our incredible speaker for sharing his insights and expertise. And of course, a big thank you to all of you for joining us, asking great questions and engaging in today's discussion. As a reminder, our recordings can be found on our YouTube channel. And we would love to hear your feedback. So please let us know how you felt about today's presentation, or any presentation for that matter we have been offering till date. If you have any questions, please stay connected and reach us out at atsri@atsu.edu. And once again, we thank you for being a part of the session, and we hope to see you again on our next event, which is scheduled on Wednesday, October 22, when Dr. Lucy Tran from the sponsor programs will be sharing information on different types of foundation grants with us. Have a great day.